very good evening to one and all of you. On behalf of the Cornea Society of India and my co-moderator, Dr. Rama Rajagopal, I welcome you all back to the second session of Kerakonnect on ocular surface tumors. We had a very interesting discussion and session the last time, and I welcome back all our panelists who are back here with us today evening for the case discussions. We have with us Dr. Santosh Funawar, Dr. Vikas Menon, Dr. Kaustubh Mulay, Dr. Bhaskar Srinivasan, and today in place of Dr. Krishna Kumar, we have with us Dr. J. Bishwas from Shankar Nethralaya. I will begin with a poll question. There's no googly this time. Shabina, can we have the poll, please? Yeah, so pigmented squamous cell carcinoma occurs due to melanoma along with squamous cell carcinoma, nevus with SCC, PAM with SCC, or is it a colonized tumor? Yeah, the answer actually is a colonized tumor. When you have tumors which are composed of different neoplastic cell types in the same lesion, you have various types of which pigmented squamous cell carcinoma falls under what is called as a colonized tumor, where you have a dendritic melanocytic population which permeates and colonizes the pre-existing squamous cell carcinoma. The next one. Reverse paradoxical maturation in histopathological examination is most commonly seen in a melanoma, nevus, PAM, or squamous cell carcinoma. So this is a feature which is most commonly seen in nevus, where you have the maturation of cells going downwards towards the subconjunctival tissue, and not a melanoma, it's nevus. And this, the next question is something which we discussed the last time we touched upon it. The most common genetic driver and therapeutically targetable mutation in a conjunctival melanoma is NRAS, BRAF V600E, or NF1. Yes, I think this is the right answer. And in fact, the newer medical management for melanoma is based on the inhibitors or the agents which target this. With this, I think we will move on to the talk that we missed in the last session by Dr. Bhaskar Srinivasan on diagnostic techniques, ASOCT and UBM in ocular surface tumors. The survey that we conducted and asked the question as to what is the most common imaging that you perform for ocular surface tumors. Most people responded, 56% responded that it was ASOCT that they do, and followed by UBM and both. So over to you, Dr. Bhaskar.
Good evening, everyone. Is my slide seen? Is my slide seen?
Yes, Bhaskar.
Yeah.
So I'll just be briefly speaking on the role of OCT and UBM in ocular surface tumors. So when you look at ocular surface tumors, the various investigative modalities that you have would be either imprint cytology, anti-segment OCT, UBM, CT or MRI, and confocal imaging. I would be focusing on OCT and UBM. When you compare OCT versus UBM, the advantage of OCT is basically it's a non-contact procedure and it prevents patient discomfort, whereas UBM is a contact procedure. The principles are the use of light in OCT versus the use of ultrasound in UBM. Resolution of OCT is generally much better as compared to UBM, but UBM gives a better image with respect to pigmented lesions, thick or elevated lesions, and if you want to image anything behind the iris. So in a clinical scenario, where do we use it? We use it to diagnose the disease. We use it to see whether the lesion is affecting the epithelium. It's under the epithelium. We need to know what is the extent of the disease with respect to scleral penetration. And it will help us in treatment planning and even in monitoring the response to a topical chemotherapeutic regime. So let's go through some examples.
Doctor, sorry to disturb. Your voice became low suddenly.
Sorry. Yeah. Is it fine now?
Yes, yes.
So the role of OCT and UBM would basically be to diagnose a disease, to document the extent or depth of the lesion, and help in treatment and monitoring the response to treatment. So going through certain examples, this is a classical OSSN at the limbus. And if you do an SD-OCT, you can actually see the increase in the thickness of the epithelium. You can see the increased hyperreflectivity of the epithelium. There is a abrupt transition of the epithelium over the cornea that you're able to make out. In this case, because of the blood vessels, there is backshadowing. So the depth of the lesion is not so clearly established. Coming to the next lesion, if you look at the OCT picture here, and this is the clinical picture, you have a lesion which involves the cornea and the conjunctiva. The OCT, this is a swept source OCT, which gives a resolution somewhere between 8 to 10 microns. And this shows the increased epithelial hyperreflectivity and thickness. It shows the abrupt transition of the epithelium from the normal corneal epithelium to the abnormal epithelium. But if you look at this area, this is the normal area. So ideally, if you have a scan through this area, it will actually show you a much better orientation of the epithelial thickness. This is another lesion where it's a much smaller lesion. It's a keratin plaque which is sitting on the limbus. And here, if you look at the UBM picture, the plaque is seen as a hyperreflective shadow. And you can make out that the underlying sclera is not involved. But if you can look at all the three images, the first one was the SD-OCT, the resolution was much better, but the depth of penetration was not as good. The second one was the SS-OCT, where the resolution was slightly inferior to the SD-OCT, but it gave a slightly better response to the depth of the lesion. But if you're looking at a deep lesion, generally a UBM will give you a much better idea about scleral involvement. So the same patient who underwent an excision, and when we are following up the patient and we've done an SD-OCT, can show you that the epithelium is of normal thickness and there is no evidence of lesion here. So the role of OCT in terms of monitoring or follow-up of patient is basically to see that the anatomy comes back to a normal anatomy. So you should see that the epithelium comes back to a normal phenotype in terms of reflectivity and thickness. So this is another patient who has a large, thick lesion at the limbus with a keratin plaque. And you can again make out the top figure is the SD-OCT, where the hyperreflective epithelium is seen, but the depth cannot be made out as well. The SD-OCT, where the depth is slightly better appreciated, but again, you can't make out whether the sclera is involved or not. And if you look at the UBM tells you that the sclera is not involved in this case. Now, this is another case where there is a nodular lesion at the limbus. It's a HIV patient where if you look at the UBM picture, it shows some areas where the posterior extent is made out, but whereas near the limbus, the posterior extent is not made out. This probably indicates a scleral involvement. Now, if you look at this and you compare what an SD-OCT shows, an SD-OCT shows a thick hyperreflective epithelium, but again, because the thickness is such, the depth of penetration is not enough. You cannot comment on the extent of scleral involvement. With the SS-OCT, to some extent, you are able to make out that the sclera is involved in this patient. If you're looking at much flatter lesions like this, which is involving the conjunctiva and the cornea, the OCT picks up the epithelial hyperreflectivity very well. And here, when you look at this is post resolution with chemotherapy, you can see a small nodule which was persistent here. And if you compare the SDOCT versus the SSOCT, here the epithelium is seen well, epithelium is normal, and there is a lesion just under the epithelium. You can't make out the epithelium as well in an SSOCT. So in this case, an SDOCT gives you a better idea that there is a remaining tumor, and you need to go ahead and surgically excise this lesion. Now, this patient had a diffuse corneal OSSN. He had been operated earlier elsewhere for a squamous cell carcinoma. And when there is no area of clear cornea, your epithelium doesn't have that abrupt transition, because across the entire cornea, the epithelium is hyperreflective and thick. So this patient underwent an excision, and it was proven to be a squamous cell carcinoma. This is a pigmented lesion with vascularization suggestive of a pigmented OSSN on the OCT, because the epithelium is thick, hyperreflective. There is no involvement of the sclera or the limbus, and the pigmentation is causing the back shadowing, which is seen here. And post immunotherapy at 4 months after interferon, you can see the lesion has resolved. The pigmentation still remains, and the OCT shows the basal layer of epithelium having a little bit of reflectivity. Another diffuse lesion of the cornea. If you look at it, you feel that this area is normal. But if you look at the OCT, even that area, the OCT shows the epithelium to be hyperreflective. It's not as thick as the other areas, but it does involve an abnormal epithelium even in the clear area. And after 2 cycles of mitomycin, it has significantly resolved, even though the OCT still shows residual lesion affecting the epithelium. And the lesion here is basically under the conjunctival epithelium. It's a pingvincula. If you're looking at an intraocular extension like this in a patient of OSSN who was operated earlier, the OCT here shows the extent of the involvement of the sclera and of the iris and the angle structures. Coming to pigmented lesions, classically as a nevus, you would normally be able to see cysts in the nevus. If you're not able to see it clinically, an OCT might still help you. You can see the epithelium is thick. There are cystic spaces which are seen, and the pigmentation causes the back shadows. Another patient with a pigmented lesion, you can clearly make out the cyst in the OCT. This patient with a diffuse conjunctival pigmented lesion, which is involving even the corneal epithelium, shows a hyperreflectivity of the epithelium on the corneal side. And if you look at the SDOCT of the same patient, the conjunctival lesion shows the hyperreflectivity predominantly of the basal epithelium, basal layer of the epithelium, and there is no lesion under it. So more likely suggestive of a PAM. And if you look at this nodular lesion extending significantly on the bulbar surface, and you get an OCT done here, because the lesion is so thick, the OCT doesn't give you much information. This is actually an SSOCT, so the resolution for the epithelium is also not as good. But if you zoom it and see, you can make out some area where the epithelium, so it's basically a subepithelial lesion, so more suggestive of a melanoma rather than a pigmented squamous cell carcinoma, where the epithelium would be primarily affected. In these large lesions or deep lesions, you would probably be better off doing an UBM to look at the penetration of the lesion into the sclera. If you're looking at this lesion, which is a salmon colored lesion at the limbus, and you look at the OCT, the epithelium of the conjunctiva is normal, and there is a lesion under the conjunctiva. It is well demarcated. It's not involving the sclera. Classically, Karp describes these lesions as hypoechoic with whitish dots, but here it is. It's not significantly hypoechoic. It's almost the same echo as the surrounding, but you can make out the nodule very clearly. And this was a benign reactive lymphoid hyperplasia. Unlike the classical description for a lymphoma, where in her publication she's shown a much more hypoechoic space with the whitish dots suggestive of infiltration with the cellular reaction. So to conclude, the OCT and UBM are basically helpful to know the site of origin of the lesion, to know whether it is epithelial or is it subepithelial, to identify the depth of involvement of the lesion, whether the sclera is involved. If you have a very pigmented lesion or a thick lesion and you are looking at appreciation of the depth of the lesion, maybe UBM would be better. If you're looking at diagnosing a nevus from a melanoma, cysts are better appreciated by the OCT. If you're looking at identifying whether it is a pigmented OSSN versus a melanoma, the SDOCT will actually give you a better appreciation of the epithelium. And finally, in all cases, you do have to correlate your clinical findings with your OCT findings, and the gold standard for diagnosis still remains pathology. Thank you.
Thanks, Dr. Bhaskar, for giving that excellent overview on OCT for ocular surface tumors. I think it is an invaluable tool in the management of these lesions. Dr. Munawar, Dr. Vikas, you have any other additional points to add on or your comments?
I think he spoke very beautifully. He covered all the aspects and showed all the examples of common tumors. I think it was wonderful. He brought out very nice points.
Dr. Vikas, you're muted.
Sorry. So I think Dr. Bhaskar, it was a wonderful talk. He even included some lesser seen tumors like BRLH and even lymphoma, OCT lymphoma, which is not so often resorted to. Extremely well described, both the imaging modalities. One thing is sometimes we do see problems like, depth, the inadequate depth, which is seen in situations where the surface is very hyper reflective. Those are still, I think, problem areas in OCT, use of OCTs and UBMs. Maybe with time, maybe we'll get better machines or with higher resolution or depth penetration. Let's hope.
Right. When OCT doesn't predict depth, UBM may be useful. In fact, it's difficult to do UBM when the tumor is all around the limbus, but then that may be a better tool to assess depth, especially intraocular penetration. UBM would be better. If you already find that the tumor is adherent to sclera and has limited mobility, then I would definitely want to do a UBM to assess ciliary body extension or full thickness scleral invasion, etc. before I would do any surgery. Difficult to differentiate various categories of lymphoid hyperplasia, benign versus atypical lymphoid hyperplasia versus lymphoma, although there are studies which have shown very subtle differences between BRLH and lymphoma. Clinically, that is not applicable because what looks like BRLH turns out to be lymphoma and vice versa on histopathology. So that's a very gray area we have. Same with PAM with atypia and melanoma. There are gray areas because PAM with atypia can look like melanoma and vice versa. So
I think what we need to understand is that it is an ancillary tool, but you cannot depend upon it to give you your diagnosis.
absolutely.
So today we have a lineup of interesting cases. But before we actually go to the first case, we have a couple of more quiz questions. Intralesional cysts are not a feature of nevus, PAM, or melanoma. So 54% have said melanoma. The answer, the intralesional cysts are not a feature of, should be PAM. PAM usually does not have intralesional cysts. They are more commonly seen in a nevus, but they can also be seen in a melanoma. What does catch melanoma stand for? Are these histopathological features that will help the pathologist catch the melanoma in the section? Are these features that are predictive of melanoma versus nevus in children? Are these features that are predictive of PAM versus melanoma or features of melanoma in a study conducted? Yeah, so 4% have said that it's predictive of melanoma versus nevus in children. You can close the. So basically, catch melanoma, its features that are predictive of melanoma versus nevus in children, a very catchy mnemonic by Shields on the particular features that basically help you differentiate nevus versus melanoma in children. Children older age, thickness or base greater, cyst lacking, and presence of hemorrhage. The last,
Why are we all so much off the mark? The answer is something else. And
we did have some of these discussed last time, Dr. Namrata.
then also,
Not all of them, but these were just certain interesting snippets which I thought, could make this a little more educative and informative.
yeah.
They would know the differences, but remembering catch as a mnemonic itself is a difficult thing, because there are so many of them.
It's almost become like a senior residency MCQ exam, which we are trying to do.
Yeah. So this is the last one. Find the incorrect match with respect to cells of origins: squamous cell carcinoma, limbal stem cell, melanoma, melanocyte, corneal intraepithelial neoplasia, wing cells, and lymphoma B lymphocytes. The incorrect match. Yeah, so most people got it right. Corneal intraepithelial neoplasia does not originate from wing cells, limbal stem cells only. And with this, we will move on to the lineup of cases that we have for today. The first case will be by, we've divided it into different categories. The first one will be on medical therapy for OSSN. And the first case presentation is by Dr. Nikhil Gokhale.
Yeah, so this was a patient who came to my clinic. He was an elderly person and he was having chronic ocular irritation for about 2 to 3 months in one eye. And he had already shown several eye doctors and cornea specialists and had tried various forms of treatment, including antivirals, steroids, lubricants, etc. His old record showed that he had a large persistent epithelial defect which took over 2 weeks to heal with a lot of lubrication. He was diabetic, hypertensive, well controlled. And when I saw him, his vision was just about counting fingers at 4 meters, and there was coarse punctate epithelial keratitis. Sensations were there, the epithelium looked irregular, and he was extremely photophobic, and there was a lot of spasm, so I couldn't examine him very well on the slit lamp. I assumed that maybe so many medications, so he had some sort of a toxicity, so I stopped everything and put him on lubricants which were preservative free. After 2 weeks, when I saw him, the patient was relatively more comfortable, but still had photophobia and coarse punctate staining, which was unusual. And looking at the slit lamp, I felt there was some sort of unusual epithelial thickening. So I did an ASOCT. Next slide. So this was the slit lamp picture which I could get at the second visit, where he was a little bit more comfortable. So you can see there is a central patch of dense punctate staining, and around that area the epithelium did look little unusually thick and a little bit grayish. However, even at this stage he was photophobic. Next slide. So I did an ASOCT which showed that the epithelium was hyperreflective and the thickness was about 80 to 90 microns. And there was an area where there was an abrupt transition to the normal epithelium. Next slide. Now, normally we say that the epithelial thickness is more than 120 microns. And hyperreflective. It's quite strongly suggestive. But here the epithelium was not very thick. So the option I had one was to do a peel off the epithelium and do a histopathology, but I deferred it and I just gave the patient 5-fluorouracil drops 4 times a day for a week. And then I saw him after a month. At this point of time, he was much better. He was very comfortable. The photophobia had gone, and now I could see a very clear patch of thickened epithelium, an island of epithelium, and the OCT showed hyperreflectivity in that area. And I repeated the 5FU another 1 cycle. Next slide. So at the second visit, now you can see that the cornea is relatively clear, and you can see a central island of gray thick epithelium, which we typically see when we have patients with corneal intraepithelial neoplasia. And here you can see again that the epithelium on OCT still shows some hyperreflectivity and thickening. Next slide. And after 2 cycles, the cornea was completely cleared up. The epithelium looked pretty normal on ASOCT. And after that, I did just put him on lubricant drops, and there was no recurrence, and the patient has followed up with, and he's absolutely asymptomatic. So this was an unusual case for me. One, because normally patients like these are not so symptomatic, or they're not having normally so much of symptoms and photophobia, but he was very photophobic, which was misguiding my diagnosis to some sort of a toxicity initially. And the ASOCT with a high index of suspicion, although I may have been wrong because we know histology is the gold standard, but because it was showing typical changes, I tried medical treatment and it was successful. Thank you.
I think that was an interesting case. Points out to how sometimes you can have these kind of situations where you might miss CIN. Any specific comments?
Well, I think
from
the
the
panelists was
panelists?
against the diagnosis of ocular surface squamous neoplasia here, because as Nikhil rightly pointed out, 120 to 130 is supposed to be a kind of a cutoff for diagnosing OSSN versus non-OSSN epithelial lesions, such as epithelial basement membrane dystrophy or leash epithelial dystrophy, etc. They can also have hyperreflective, hyperplastic epithelium, 80 to 90 micron thick, but not 120. Whereas OSSN is supposed to, that is a cutoff. Of course, you cannot say that if it's less than 120, it cannot be OSSN, as has been shown here. So this is one odd situation. Another feature which was suggestive of OSSN here was the abrupt transition, which is not seen in epithelial basement membrane dystrophy or leash epithelial dystrophy. So I think features were in favor of OSSN and the patient rightly responded. So we have to, I think, keep our eyes open and be sensitive to the possibility of OSSN in atypical epithelial lesions. That is the lesson.
Geeta, if I may ask a question, I do understand that impression cytology has a lot of limitations. In this case, would it have been a good suggestion? Would we have considered impression cytology in this case before we decided on the treatment?
There's no harm to do the impression cytology.
Yeah, classically, I think whenever we suspect, we would just go ahead and do impression cytology first before starting treatment.
Once or twice earlier, when I had such cases where there was a pterygium with an unusual gray epithelium, what I did was in the OT just peeled off the epithelium. Because it's a thick sheet, it peels off well and stays like that. And I fixed it with formalin or whatever, and I sent it. And I think the pathologists were able to sort of comment on the picture. Because impression cytology at my place, I'm not very comfortable, or maybe we're not still doing it. So I realized that if you have a thick sheet of epithelium, it peels off well and it doesn't disintegrate if you fix it up, and then you can try to send it. Maybe you could do that.
The other thing that was there was the location of the lesion. It was at a point where the epithelium meets. That's the the meeting point of the epithelium originating from the limbus is not the center; it's slightly below the center. So your lesion was, so it maybe could have been the stressed epithelium that were not able to differentiate properly, and with your treatment that you gave, maybe the lubricants and everything, it allowed the healthy epithelium. That's why you could see that the end point of your lesion was also located at that same point where you see the old epithelium, that kind of. So that is again something that if you had removed the epithelium, done a histopathology, I think you would have had a conclusive diagnosis. But again, that would be in the differential. One would be a CIN, but isolated CIN without any lesion going towards the limbus or having it's kind of a little second on my list. It wouldn't be the top one. But I agree, your wonderful documentation with the anterior segment OCT, the abrupt transition, and these are things that can definitely help us, identify these lesions.
The morphology of the lesion was also altered because there were so many medications that was given to this patient before we actually.
Right.
Dr. Nikhil, very beautiful photographs and wonderful documentation. Now, the picture was definitely atypical rather than being a typical pure corneal OSSN, and clinically it was definitely a difficult diagnosis to make. My only query here is that your patient was symptomatic, having a lot of photophobia, and in such patients normally we would prefer a milder drug like maybe an interferon to start with. Did you have any particular reason to start with 5FU?
Very frankly, at least I find a lot of difficulty in getting interferon here. So I have been using 5FU. I think it works faster than interferon, and actually the patient did pretty well. He became so asymptomatic after the first cycle itself. But I agree, normally otherwise most people nowadays prefer interferon as it's less toxic and probably, maybe a good drug as well. I agree, you could have used that.
On 5FU, are you considering punctal occlusion in these eyes?
No, I haven't done actually punctal occlusion, although I think there was some discussion last time that we should do it.
If there are no more questions, we'll go on to the next case, which is by Dr. Srilata. She'll be presenting a case on bilateral recurrent OSSN in a post-renal transplantation.
Good evening, everyone. At the outset, I would like to thank the Cornea Society of India for giving
Sorry,
me this.
I think louder. Srilata, louder.
Is it better now, ma'am?
Yeah.
Okay. So I would like to thank the CSI for giving me this opportunity to present my case on bilateral recurrent OSSN in a renal transplant recipient. Next slide, please. So my patient is a 67-year-old male who had come for OPD with 1 year history of bilateral conjunctival mass. His past history was significant in that he had undergone a right radical nephrectomy for renal cell carcinoma in 2011, and after which in 2015 he had undergone a renal transplant in Vedanta. He was a known hypertensive and diabetic for 12 years. On ocular examination, the slit lamp revealed a classic bilateral OSSN with corneal involvement. There was no doubt in any diagnosis, and we went ahead with a surgical excision. We did a complete excision with adequate clear margins. And his histopathological report showed that it was a conjunctival intraepithelial neoplasia. Next slide, please. At the time of presentation, this is the picture that we had. The right eye showing a thick, large, leukoplakic kind of a lesion at the temporal limbus with a feeder vessel, and a similar large lesion with a gelatinous pinkish appearance in the left eye with the feeder vessel. So this was a classic presentation of OSSN. Next, please. So after the excision, patient was seen on follow-up 3 months post-excision. He was all fine. Both the limbus clear. There was no suspicion. He was fine, and he was only on lubricants, and he was sent back for a 3-monthly follow-up. He came later to us 6 months post-surgical excision. Next slide, please. And that is when we found that in the right eye, if we see on this indirect slit illumination, we could see these corneal lesions coming in. There was a small limbal plaque, but mainly there was a predominant corneal lesion coming from the temporal limbus in the right eye. A similar, another lesion was found in the left eye too. There were limbal nodules, 2 limbal nodules found in the left eye. Now, with the background history that we had done the excision, we knew that this was a classic recurrence of OSSN in this patient. As Dr. Gokhale had already spoken, so these days we have the first pump surgical agent preference for interferon. So we had started the patient on topical interferon, alpha-1 2B, 1 million international units per ml, the QID dosing. And the patient was followed up. Next slide, please. 2 months after the initiation of therapy, we found that there was practically no change in the lesion. In fact, in the right eye, we could see that though it started more as a corneal lesion, the limbal plaques was much more prominent now. And so in the left eye, the nodules were still persisting. This was something very intriguing because we know that interferon normally acts very well. And for lesions with such a size where it is even less than 1 clocker in the left eye and less than 2 clockers in the right eye, we would generally expect a good response with this drug over this 2 months period. But this was something intriguing. And that's when we thought that, we should switch to another drug, and we changed the chemotherapy from interferon. We switched to mitomycin C 0.04% QID with a 2 weeks on and a 2 weeks off cycle. Next slide, please. So this was the presentation after initiating mitomycin C after 2 weeks of on treatment. If you see the right eye, the limbal plaque had reduced much in size and the density, and even the left eye, the nodules were appearing to regress. This is the classic hyperemic picture of patient who is on mitomycin C. Vis-a-vis interferon, we saw that patient was much quieter eye, but here with mitomycin C, a bit conjunctival inflamed eye. So we saw that the lesions are regressing, and we continued him on mitomycin C for 2 cycles with 2 weeks on and off. And at the end of 2 weeks, at the end of 2 cycles of mitomycin C, it was completely resolved. Next slide, please. So this was after 2 cycles. There were no more lesions in the right eye. The right eye temporal limb was being absolutely free. And so in the left eye too, the limb was being absolutely free. There were no more nodules. So we found that this patient responded to mitomycin C and not to interferon. Again, this was something very atypical. And then we looked up, next slide, please. So in our case, we found that there were these 3 unique features. First, he presented with a bilateral OSSN, and he had a bilateral recurrence. And there was a non-response to this topical interferon drug, even after 2 months of treatment for the recurrence. And all of these features we could have put in one shell, because the patient was an immunosuppressed patient on tacrolimus because he was a renal transplant recipient. All of the immunosuppressed nature of the patient could explain these features in our patient. And when we looked up in the literature, there was one case report published in the Cornea Journal. Next slide, please. Which showed that, there were, this is a case report of 3 patients wherein they found that who were again immunosuppressed males, they were not responding to topical interferon even after 2 to 7 months of treatment. All the 3 patients were having some kind of hematological malignancies. One was non-Hodgkin's lymphoma, one was leukemia patient, other was multiple myeloma. And again, they found a similar complete resolution after switching to 5-fluorouracil or mitomycin. And here they concluded that intact immune system is an important link for interferon to act in a patient and for the OSSM to resolve. So then it is suggested that in patients who are who fall in this category, whether they are immunosuppressed, it is better to start on 5-fluorouracil or mitomycin C instead of immunomodulating drug like interferon. Next slide, please. So the point from my case would be that we saw in our case that interferon was not effective. Interferon is not effective in OSSM patients on immunosuppressants, since their primary mechanism of action is through immunomodulation. And our case highlights the above during the treatment for recurrence, as the patient was a renal transplant recipient on the left. Next slide. Yeah, I want to thank my oculoplasty colleague, Dr. Swati Bansal. She operated on this patient. Next slide. Thank you all.
Shraddha, that was a very beautifully documented and well managed case. The one question I had for you is that in the first instance itself, when you had a bilateral lesion, would topical chemotherapy have been an option at all for you or no? Would you have liked to consider topical chemotherapy in the first instance itself? Because your lesion is small, it's peripheral, it's corneal, so is that an option at all? Can you hear me?
Yes, ma'am. So at the first instance, yeah, it was a bilateral mass, and because surgery is still considered the first line of management in many patients where it is less than 4 clockers of involvement, so we went ahead with surgical resection.
Right.
And the patient.
So I do agree. We have also seen a patient like this who had a bilateral peripheral lesion, similar looking, not so big, but in the cornea. This was few years ago, and between mitomycin and interferon, patient opted for mitomycin because he could not afford interferon. The lesion resolved beautifully with mitomycin, and we have follow up of almost 4 years with no recurrence. The point I think we did discuss last time also in our meeting last time in Kerakonnect, that this is just an evolving concept. I think that about whether we can use interferon or not in an immunosuppressed patient. In the same context, I would like to ask the panelists about what do they think about the role of CD4 count in monitoring CD4 count in a patient who is having HIV and at the same time having a corneal lesion. How often would do we really want to consider the CD4 count at all as one of the indexes for looking at the response to topical chemotherapy? I would like the panelists to give us their opinion.
I don't think that would really help. I mean, CD4 count obviously is an index of prognostication or how the patient is doing with antiretroviral therapy, but I don't think it has an implication on the control of OSS, and I have not come across any literature to that effect. But basically, in a situation where there is OSS in an immunocompromised patient, there could be two mechanisms. One is human papillomavirus induced mechanism of OSSN. Second would be the OSSN that develops without HPV involvement, P53 induced mechanism. And interferon can work both as an antiviral. It is known because there are certain products that are produced by interferon, such as interferon induced genetic modification, which is virus specific. And also interferon can work by upregulating IL-2 and downregulating IL-7. That is one of the mechanisms, because of which it has an anti-neoplastic activity as well solely, and it can have a combined activity. When it is given topically, it has mainly antiviral activity. When it is given in the form of a higher dose, that is injection, 3 to 10 million international units, then it has anti-neoplastic activity. So in which patient, what we are looking at, since we are not very sure of the etiology of OSS and what triggered OSS in an individual patient, in some patients it may work, some patients it may not work. Even in fully immunocompetent patients, there are situations in 20 to 25% of situations where interferon does not work at all, where you have to switch over to mitomycin or 5-fluorouracil, and vice versa. There are occasions when 5-FU and mitomycin don't work, and when you switch over to interferon, it works beautifully well, right? So there is some hazy understanding of this concept yet. We are not very sure in which cases is it going to work. There are no prognostic factors at this point in time.
Thank you.
I think I just want to highlight one thing, that whenever we have a case of OSSN like this, and like Dr. Rama also pointed out, we would first go in for a chemotherapy. And I mean, the thing that we follow is first go in for mitomycin, see if it doesn't work, then go in for topical interferon. So it is like that. So I don't know how many on the first instance will only go in for chemotherapy for this case, and more so because it is bilateral.
Not really. There are specific indications for topical therapy. In fact, there are specific indications for surgery. There are specific indications for topical therapy. And there is a gray area. This falls into the gray area. It depends on the surgeon's choice, whether patient wants a one-time cure or not. If a patient wants a one-time cure without having to be compliant with topical medications, then surgery is definitely an option, even in a bilateral situation. But if it's a corneal OSSN, like the case that Nikhil showed where the pupillary axis is involved, or the tumor which is placoid involving more than 6 clock hours of the limbus, or a diffuse lesion involving more than 50% of the ocular surface, then topical therapy is probably the primary treatment of choice. Surgery is the second treatment of choice. Where vision is at compromise, where limbal stem cell deficiency is a possibility, where the patient needs extensive surgery, then you would lean towards topical therapy. And this definitely is in the gray area where both options are absolutely right.
That's the point that I wanted also to highlight, in the sense that there is an increasing tendency among people that they want to treat all OSSN with chemotherapy. That means the ones which are very well defined, small in size, which can be very easily surgically excised with clear margins, but you want to treat with chemotherapy. So do you think that's a right approach?
We also tend to think, that the topical chemotherapy will have some kind of a debulking effect.
Right.
Even if it does not it does not treat completely. I mean, at least for the larger lesions, that is the rationale of starting. If it does not treat completely, it will at least, take it to a level where it is treatable. So like in this case, I mean, I agree with Rajesh on that, we tend to go in for chemo first, and then topical chemo first, and then for surgical excision.
Rajesh, I tend to agree with you, because there is an increased tendency for sure. But if they have been very careful with their evaluation, like if they have already assessed the depth and staged the disease, AJCC has very clear-cut staging. But then once it is gone beyond the, say, on the corneal side, beyond the Bowman's membrane, or on the scleral side, it is, if it's infiltrated the superficial levels of sclera, or if it's in the fornix or in the palpebral conjunctiva, then topical therapy does not work. So we have to choose surgery, in favor of surgery in those patients, or injections.
Yeah, but then in the routine clinical practice, what you see is superficial. You are not able to assess the depth of the lesion. So that's where I'm saying that by treating with chemotherapy, sometimes there can be instances where you can miss out, where you have not been able to evaluate the depth of the lesion. Like in my practice, if I don't see a significant number of tumor cases, if I see a patient with a larger lesion, I will not keep treating the patient. Maybe I'll refer the patient to you, where you have the ability to, evaluate and provide the best of the care for the patient. So just because interferon or 5-FU is available and I can prescribe it, I think for lesions which don't look small or which they look larger and you think that you cannot manage them well, I think they should be referred to a tertiary center rather than, because by the time you send them later, they would have infiltrated far more and the management may become a little bit more difficult.
Yeah, so in the fornix, refer to oculoplasty surgeon. Then we have nothing to do with it. The moment it leaves the cornea, and it's
depth is more important, Rajesh. Yeah, more than extent, depth is more important. And if by 6 weeks the patient hasn't responded, or to one cycle of mitomycin C or a couple of cycles of 5-FU, or about 6 weeks of continuous use of interferon, if there is no response, or if there is the first sign of increase in size, then obviously we are on the wrong track.
These were some of the points that we highlighted in the last session. And the first question that we started off with is basically, when you're starting topical chemotherapy and you don't do a biopsy, what implication does that have? So once we understand that, and then we, apply that to the patients that we are seeing, and like Dr. Onawar mentioned, mobility is something that helps you to give you some idea regarding the penetration into the sclera. So if it's a fixed lesion, you're probably thinking more in terms of something which has gone in, except at the limbus. So you have to use your clinical acumen to decide whether you would want to start topical or you would like to take the patient up for surgery. So we'll proceed to the next patient, which is also a medical management using topical mitomycin C. This will be a case by Dr. Sonia Kothari.
Yeah, good evening. Thank you. I thank Cornea Society of India for giving me this opportunity to present my case today. My case is a patient with wherein topical mitomycin C was used as a primary mode of treatment in ocular surface squamous neoplasia. So this was a 66-year-old female who presented with slit lamp evaluation showing a papilliform growth on the limbus, which was almost 5 millimeter by 7 millimeter. It had all the typical features of OSSN, which were described in our last meeting. It had a presence of feeder vessels, presence of intrinsic vessels. There was perilimbal involvement from almost 10 o'clock to 5 o'clock, and rose Bengal stain was also positive. Next slide, please. Based on these clinical findings, we made a diagnosis of OSSN, and since the lesion was very big and involving the large part of limbus, and we decided to go ahead with treating medically first and to achieve a chemo reduction. And once the tumor has reduced in size, we thought that we will go ahead and do a wide surgical excision using 4 millimeter of clear zone, and do a double freeze cryotherapy followed by an amniotic membrane grafting. So so the first cycle of mitomycin was given. Next slide, please. And there was on the day 7 of starting mitomycin, there was a significant reduction in the size of the tumor mass. Almost 30 to 40% of the tumor had reduced in size, but there was no significant reduction in the perilimbal involvement of the OSSN. Next slide, please. So we continued the mitomycin because the response to the treatment was really good. And on day 21 of the first MMC cycle, we saw that there was a significant reduction, almost 80 to 90%
of the tumor mass has reduced in size, and there was a simultaneous reduction in the perilimbal involvement also. From 10 to 2 o'clock, almost the limbus had completely resolved. So we completed the first cycle. We gave the break area to the patient, and 10 days after the first MMC cycle, the clinical presentation was as seen below. There was almost complete resolution of the lesion with absence of the perilimbal involvement. The feeder vessels were also not seen, and there was no keratinization. The rose Bengal stain was also negative. Next slide, please. Since there was no lesion which was clinically seen on the slit lamp, the treatment plan we changed. We had initially decided to do the surgery, but since the response was very good, we decided to continue only the topical mitomycin for a total of 3 cycles. And these are the 2 images which we can see after the second MMC cycle, and after the third cycle, there was no lesion left behind. Only a minimal conjunctival congestion was seen at the end of the third cycle. Next slide, please. So as we all understand that surgical resection has always been the gold standard of treatment for OSSN, but MMC and the other topical agents are increasingly being used now as a primary treatment or with adjunction of the surgical resection, either before as a chemo reduction agent intraoperatively or more post-operatively as a chemo preventive agent after the procedure to reduce the risk of recurrence. Next slide, please. So topical therapy really is inexpensive. It is simple to use. It reduces the risk of limbal stem cell deficiency and obviates the need of a clear tumor margin by treating the entire ocular surface, including the potentially dysplastic cells. However, the long-term studies are required to monitor the effect and complication of this treatment modality. Thank you.
So that was well documented, Dr. Sonia. The only question that we had here was, you said you used a 21-day on, 21-day off cycle of, you need to unmute yourself.
Yes, ma'am. So we did the 3 weeks of on cycle and 3 weeks of off cycle for this particular patient. It was done in conjunction with our oculoplasty surgeon.
Right. So when we talk about continuing the mitomycin C or your topical therapy for a certain period of time after clinical resolution of the tumor, here in this instance, you have used it for 2 more cycles, which means that another 3 weeks, then another 3 weeks. Is that right?
Yes, ma'am.
So would that much amount of mitomycin really be required in this situation? Because normally when you talk about continuing interferon for approximately 6 weeks after complete resolution or 5-FU for 2 cycles, which is like a 1 week on, 3 week off in case of 5-FU. A 3-week cycle, doing it 2 more times after complete resolution, I'm not sure if that is an overkill in the situation, considering that mitomycin C does have.
Yeah, when I was thinking back on the same case, I also thought that maybe we could have on the second cycle and the third cycle, maybe reduced it to a 1 week or a 2 week of on and a 3 week of off cycle. I mean, reduce the mitomycin, but we really didn't see a lot of ocular like surface. I mean, there were not many SPKs, or the ocular surface was maintaining good health throughout the course of the treatment for the patient. And we have a follow-up of 6 months after the last treatment, and patient is still maintaining a good ocular surface with no recurrence of the OSSN.
Should also look at puncta. While giving such a prolonged course of mitomycin.
Yes, sir.
Punctal stenosis is a significant complication both with mitomycin and 5-FU also.
Yes, sir.
Add surface steroid or anti-inflammatory agent with your 3-week cycle of mitomycin?
No, we did not give any anti-inflammatory. We did give lubricating drops though, but no anti-inflammatory was given.
So I think the one point I would like to make is this is classically, I would say, a lesion besides the corneal intraepithelial neoplasia. Most of the times when you have a conjunctival lesion, they are mostly papillomatous, which are large, which require chemoreduction, unlike the gelatinous or other forms, morphological forms. And this responds very beautifully. The response to papillomatous lesion with mitomycin, I feel, is much faster as compared to interferon, maybe because one school of thought says that it has rapidly dividing cells, so that's one of the reasons. So like we discussed in the last meeting also, what starts off as chemo reduction can sometimes end up with chemotherapy. That is why you need to monitor the response very closely, both in terms of the size of the lesion and the height of the lesion. And if you see the response is very good like what you have, we may as well end up with a complete resolution without surgery. But like you rightly said, you really need to follow these patients over a long period of time.
Yes, I agree to the long-term follow-up which is required for these patients.
There's a question in the chat actually, which somebody has asked that how many days or how many months of treatment we should do before we decide that this drug is refractory or the tumor is not responding. So I'm sure it must be different for each agent. So are there any standard guidelines if anyone can share? Like how many days of interferon or how many cycles of MMC? After that, you would say, okay, change the medicine.
For interferon, it is 6 weeks, Nikhil. For 5-fluorouracil, when you give 1 week and 3 weeks without treatment, at the end of 4 weeks we assess. Same with mitomycin, at the end of 1 week we assess, 1 cycle we assess. If there is no change at all, then the drug is not working. If it's progression, obviously drug is not working.
Similarly, I think once you have clinical resolution, it's the same logic. You use interferon for 6 weeks after clinical resolution, and you use 5-FU for 2 more cycles and mitomycin for 1 more cycle after
Correct.
clinical resolution.
Correct.
Dr. Rama, you have to unmute yourself.
We'll move on to the next case presentation by Dr. Raki. She will present a case on spontaneous intratumor bleed in an OSSN.
Good evening, everyone. First of all, I would like to thank CSI for accepting this case for presentation. So I'll be presenting on spontaneous intratumoral bleeding following medical therapy. Next slide, please. So this was a case of a 48-year-old male presented to us with complaints of a mass in his right eye since 14 months, which was increasing in size and associated with watering and foreign body sensation. And patient didn't give any history of trauma or ocular surgery or any systemic illnesses, and he was non-alcoholic, and he was not on medication at that time. Next slide, please. So ocular examination revealed that there was a mass of 7:5 millimeter, and it was present in the inferior temporal quadrant of the cornea, extending 6 to 9 o'clock. And it was fleshy, mobile, pedunculated, and it was an elevated with the irregular surface and multiple vascular cores associated with multiple tortuous dilated fetal vessels, and rest of the things were normal. Next slide, please. So we did a UBM to rule out any intraocular and scleral invasion. The sample was sent for impression cytology, and few dysplastic cells were seen. Laboratory parameters showed normal results, including CBC, LFT, RFT, and viral markers. So we provisionally diagnosed this case as a OSSN, pedunculated, inferior temporally located, and papillomatous morphology. So we started interferon alpha 2b 1 million international unit per ml drops for 4 times a day, and monitored this case at a regular interval to see the response of tumor to the treatment in terms of size and vascularity and regression. Next slide, please. Next slide. At 2 weeks, patient had slightly regressed tumor, but without any change in the vascularity. But after 3 weeks of therapy, patient called and informed us that about that sudden appearance of bleeding in his eyes. So we examined and found that there was a big hemorrhagic spot inside the tumor, inside the mass, and there was no obvious bleeding present over the surface or around the tumor. Beside this hemorrhage, we could also notice the increase in the conjunctival congestion, and the stem of the tumor was clearly visible in this vision. So keeping all this finding in mind, we continued the therapy with interferon with the same doses. And after 2 weeks of this episode, we again examined the patient, and we were surprised at that time because we found no evidence of tumor, except there was a debrided, deepithelialized oval wound measuring about 2 to 2.5 millimeter, and a few vessels were approaching to the epithelial defect, and few plaques were present over the limbus. So the treatment continued, and after 8 weeks of therapy, the complete resolution of tumor was seen. Next slide. So we had a complete resolution of tumor in the period of 8 weeks. We encountered two complication, or you can say events during the course of therapy. One was mild conjunctival hyperemia, which was increased at the time of episode of intratumoral bleed. And another one, which was very unexpected to us, that was intratumoral bleed after 3 weeks of interferon therapy. And there was no recurrence found in the 3 years follow-up. Next slide. So we kept two thoughts as a probable causes for this event of intratumoral bleeding. One was that it could be a complication of topical interferon alpha 2b, but we failed to find any possible association of interferon 2b with any kind of intratumoral bleed in the literature. And second one was maybe due to the mechanical trauma. And since the tumor was pedunculated and located in the inferior temporal quadrant, so the regression of the tumor size might have resulted in increased mobility of the tumor that led to mechanical trauma while blinking, and eventually bleeding from the new vessels. This was just our thought, but it was not supported by any evidence, and the histopathology could not be done because tumor was not present, and it was missed, it was lost actually. Next slide. So was all about of this case, and I would like to have comments from panelists that how common intramural tumoral bleeds can be seen in cases of OSSN, and can it be an adverse reaction from interferon, or it may be one of the mechanism by which it acts on these tumors. Thank you so much.
So this was a very interesting case actually. The only two times where we have seen a spontaneous resolution of the tumor is first case. What was common, I think, was the same location. Now that you are saying it was inferotemporal, it was a HIV positive patient who had a papillomatous pedunculated lesion. Was advised surgery, but came back after 2 months, and when he came back, there was almost an 80% resolution of the size of the tumor, which was surprise to us. We really couldn't explain the reason for why this happened. That's why I was wondering, does it have anything to do with the systemic immune status? The second lesion was a very small lesion. It was mostly a keratin with a stuck-on appearance, which probably fell off because of the lid action. So I really don't have an explanation for this. Maybe the panelists can throw some light on this.
I don't think there's an association between a hemorrhage and interferon use. It's been used very widely and very commonly. And I don't think it has been reported as a specific feature of interferon therapy or mechanism of action. The second thing is we don't know whether it just fell off or it resolved spontaneously. So
it was actually fell off because patient called me and said the same thing, that tissue has dropped, and we could not find it where it is dropped. So
Possibly
I'm sure about it that it was full.
Possibly it was a necrotic reaction. Basically, when the tumor necroses, there can be intralesional hemorrhage. interferon, in fact, is reduces vascularity. That's one of the mechanisms by it works. It is anti-angiogenic. That is one of the clear mechanisms. But if the tumor is resolving and if it is necrotic, then there is a chance of intralesional bleeding because of unstable capillaries, and such a necrotic tumor can just slough off.
I think a few things at the end of the cases that we have for the medical therapy part of it is uh, all of us seem to have different medications out of the three that is available, which we start as our first line of treatment. We have seen cases where people have started on interferon or 5-FU or mitomycin, and also a few different cycles that have been questions regarding the actual the cycles and the dosage, which were covered in quite a lot of detail the last time, and we will be sending a summary of the last meeting to the members. And I think Dr. Onawar is giving the details of the various protocols which are currently in use. So it might be safe to say that you need to take a decision regarding initiation of topical therapy appropriately, and then you can use the drug of your choice, but use it in the right fashion and make sure that the lesion is responding, and continue to follow up the patient till you decide whether the patient would require surgery or it would resolve completely with chemotherapy itself. I think with this, we'll move on to the second part, which is on surgical treatment of OSSN. And the first case here is by Dr. Richa Diman on Alloslet in diffuse recurrent OSSN.
Evening, everyone. So at the outset, I would like to thank CSI for giving me this opportunity. So this is a case of Alloslet in diffuse recurrent OSSN. Next slide, please. So she was a 43-year-old female who presented in November 2018. She had underwent excision surgery in left eye in 2016 elsewhere, which was reported as Bowen's disease. Although no prior reports or pictures were available, she had a history of allergic conjunctivitis in both eyes and clinical signs of VKC in the right eye. This time she presented with an epithelial defect, which was managed with BCL, topical lubricants and FML, and the defect healed. But there was a suspicious limbal hypertrophy as is seen in the picture from 4 o'clock to 10 o'clock position. And with the suspicion of OSSN recurrence, we did impression cytology, which did not show any atypical cells. She was not an immunocompromised patient. The patient was kept on a follow-up. Next. And in February 2019, we noted rose Bengal staining involving the center area of the cornea. Next slide, please. And in April 2019, there was a diffuse lesion involving the cornea as well as conjunctiva, although not very typical of OSSN. But again, when we repeated the impression cytology, next, please. It showed atypical cells along with mild increase in the epithelial thickness in ASOCT, and hence we started the patient on topical chemotherapy in the form of interferon alpha 4 times a day in left eye. Next, please. Although after 2 months of starting the topical chemotherapy, the patient did not respond, and there was increase in the lesion, which is noted with the help of yellow mark. Along with on ASOCT, there was increase in the epithelial thickness, and on confocal, next slide. On confocal, there was a starry sky appearance representative of the hyperreflective nuclei, and hence we decided to do a wide excision biopsy. Next slide, please. Now, since when we will be doing the excision biopsy in such a case, there will be a large bare area. So along with the wide excision biopsy, shown with the help of green arrows, we decided to move ahead with SLED. Now we decided Alloslet in this case because the other eye of the patient was symptomatic, VKC, and the patient was not ready for the limbal biopsy from the other normal eye, and hence Alloslet was decided upon. Post-operatively, the excision biopsy showed microinvasive squamous cell carcinoma with margins involved. 2 months post-op, next slide please. The surface epithelialized well with a central scar formation. Although there was a lesion marked in green color noticed in the superior quadrant, and hence in view of margin involvement and recurrence, The patient was started on mitomycin C, 0.04% 4 times a day. Now here we started mitomycin C because initially patient did not respond to interferon alpha, and hence issues associated with toxicity and post-allostate, they were considered. Now post 2 cycles of mitomycin C, next slide please, the lesion resolved well with decrease in the epithelial thickness as represented on the ASOCT and maintenance of a normal epithelial contour on the confocal microscopy. The patient maintained a vision of 6/12, corneal phenotype was maintained. Hence, next slide please. In such patients, whenever there is a large diffuse lesion, the timeline of events play an important role. And now in our case, there was initial no response to the topical chemotherapy, which might be attributed to non-compliance of the patient. Whenever there is such a diffuse lesion, we need to decide upon SLET. But if the residual functional stem cells, they are enough to continue proliferating and maintaining the corneal phenotype, there is no need of SLET, either auto or allo. And if we are doing autoslet in such cases, we are basically transferring the stem cells of the same genetic makeup and the environmental exposure with an additional surgical insult from the non-affected eye to the affected milieu. Plus, there is always a possibility of recurrence in such cases, in which case we will be losing the precious limbal cells, which can be used for subsequent rehabilitative process. And hence, in such cases, we suggest that alloslet will give a stopgap option bypassing the above, and hence we can do autoslet later if needed. Thank you.
I think, are there any cases of alloslet for similar, have been described earlier? I can't think of, I can't remember seeing any. I think this must be the first of its kind.
Yeah,
yes,
there is no publication so far on alloslet. Richa, are you there? There
yes,
is no.
I don't think there is any. It was a very clever thing to do, and I think perhaps a right thing to do also. But I don't think alloslet has been described before for OSSN like this, such a diffuse kind of an OSSN.
Yeah, so we basically tended to veer towards alloslet in this case because she was symptomatic in the other eye. She had an active allergic conjunctivitis. There are 2 earlier reports where autoslet has been used. Dr. Munawar himself has published a multicentric case series with Dr. Vikas Mittal and Dr. Bhaskar Roy Chaudhary. And there's also a publication from Dr. Swati Kalki where autoslet has been used. The only issue that we have with the use of autoslet, like Richa mentioned in the last slide, was the possibility of a recurrence, the need for post-operative topical chemotherapy or a resurgery, or these are things which can compromise your SLET. And sometimes you might not even need a SLET except to help facilitate the epithelialization in the postoperative period. Like in this patient, she's not on any immunosuppression. She's just on lotepred 2 times a day, but the corneal phenotype is maintained. So you really don't know whether these patients would go into LSCD or not. And you're doing an autoslet for an anticipated LSCD in this situation. So, which is the reason why we thought that alloslet would probably be a better option than do an autoslet.
Has this patient used any long-term cyclosporine or tacrolimus for allergy? Because why did the tumor come in the first place? If we have explanation.
No, she was not on any medication. In fact, she was not even on significant topical steroids in the other eye till she presented to us. In fact, we have another case lined up also where we have used alloslet, but that comes a little later. Maybe we can go to the next case if there are no other questions.
But you use mitomycin post-operatively once the surface got epithelialized. So even the surface would have been quite fragile with the alloslet. So did you encounter any erosions or epithelial defect?
The reason why we used mitomycin was because the earlier lesion did not respond to interferon, which was why we had to consider using mitomycin, knowing fully well that we were dealing with a surface which was immediately out of a alloslet. and the issues of toxicity, but we gave mitomycin along with lotepred. And fortunately, we didn't encounter any toxicity related issues. And in one cycle itself, that suspicious lesion resolved completely, and she required only 2 cycles of mitomycin C. And after that, she's come back for a follow-up 2 months later, when you can see that the corneal phenotype is well maintained and the surface is absolutely fine.
Just curious to an extension of what Nikhil had asked, in the sense that if patients have this chronic allergic eye disease, the limbus is very active, throughout the allergic episodes. So have there been any cases of dysplastic changes reported because of this? We know that partial limbal stem cell deficiency can occur with this kind of prolonged limbal inflammation that happens in allergic eye disease. But has any dysplastic cases, dysplasia been reported or anything? Santosh?
Yeah, Rajesh, I have a few cases where young children and teenagers actually with long-term VKC have developed OSSN. One of them has developed unilateral OSSN and one of them has developed bilateral OSSN. So that is a possibility because of long-term, irritation being one of the factors, long-term inflammation and consequent changes in the cellular level being one of the factors for induction of OSSN. This is a possibility. Even in patients who have had acid-alkali burns, OSSN is a possibility, and I have one such patient. That doesn't prove anything, but that one of the factors possible.
Even I had a child with this kind of, which was being treated as, limbal inflammation, and we were suspicious, did a biopsy, and it turned out to be lymphoid reactive hypoplasia.
Right. Even lymphoma has been reported in children with VKC.
But why would the chemical injury have OSSN?
Chronic irritation possibly is one of the risk factors.
Yeah.
Patients who have RGP use for a long time, they can develop OSSN. In the various, of course, these are only case reported. Doesn't really prove anything or disprove anything, but you should possibly consider when some patient who has had this has a atypical conjunctival lesion, you could possibly consider OSSN as one of the differential diagnoses.
We had a patient many years back, a young boy who had nocturnal lag ophthalmos, and the inferior exposed cornea had dysplastic change, which subsequently he continues to tape his eye with copious lubrication in both the eyes after that. He surgically exposed the lesion many years back, and he's still continuing to follow up. So like you said rightly, any cause of constant irritation could possibly give rise to a dysplastic change.
We'll move on to the next case now. It will be presented by Dr. Hiren. This will be a case series on corneal involvement in xeroderma patients, surgical management options.
Good evening, everyone. I'm grateful to the CSI for giving me this opportunity. Cases of corneal involvement in XP. Next slide, please. So the first case was a 35-year-old male, was a known case of XP, and presented to us with the complaints of noticing a white mass in his left eye, along with diminution of vision since 5 months. The BCVA in the affected eye was 6/24, and the other eye was normal. Slit lamp examination, as you can see, revealed a firm nodular ulcerated mass in the inferior part of the cornea with no palpable lymph nodes. UBM showed up to mid-stromal corneal involvement. It was decided to go ahead with lamellar keratoplasty and, if needed, a PK. Next slide, please. So firstly, alcohol epitheliectomy was done, and the mass was excised with 3 millimeters margin. On dissection, about 40% of the corneal stroma was found to be involved. Further dissection was carried out up to 60% of corneal depth, and then application was done to the conjunctival margins and at the limbus. Then a 7 millimeter lamellar corneal patch graft was sutured with 10 nylon sutures, and amniotic membrane grafting was done. Histopathology revealed invasive squamous cell carcinoma. And as seen in the picture, there was no recurrence at 4 years of follow-up, although the graft had failed. Next slide, please. So the next case was a more superficial case. The patient was a 36-year-old male And he presented to us with a nodular pigmented mass on the cornea, as seen in the slit lamp photograph, in his right eye. UBM On UBM, the lesion did not appear to involve the deeper layers of the cornea. Hence, it was decided to go ahead with excision along with cryoapplication with amniotic membrane grafting. In this case, also the HP showed squamous cell carcinoma. There was no recurrence at 2 years of follow-up, as seen in the post-op image. The last case was a 28-year-old male, a known case of XP, who presented to us with the complaints of diminution of vision in the right eye. Since 1 year, the left eye had to do LSCD. We decided to do a lamellar keratoplasty in the right eye along with cryoapplication. But on table, as you can see in the second photograph, the DM appeared to be scarred and a fleshy mass was found to be firmly adherent to the central DM, as seen in the second image. Hence, PK was done along with cryo application. And as you can see in the third photograph, at 4 o'clock, an iris strand was adherent to the cornea, which was excised, and the graft was secured with 10 nylon sutures. 9 months post PK, we decided to go ahead with the cataract extraction along with IOL implantation. The patient presented to us after 2 years with a suspicious lesion on the nasal and temporal region, as seen in the photograph below. And an excision biopsy along with cryoapplication with AMG was done. In view of the graft, topical chemotherapy was deferred. And as seen in the last image, at 2 years of follow-up post-excision biopsy, no recurrence was noted, and the BCVA was 6/18. Next slide, please. So the key points from these cases are corneal stromal involvement is rare, but it occurs especially in higher situations, as seen in the above cases of XP. Bowman's membrane, as we all know, offers a protective resistance to invasion by the tumor. From case 1, it can be said that lamellar keratoplasty can be preferred because PK carries the risk of intraocular seeding of the tumor. One point of discussion here can be the treatment options for the base of the lesion on the residual corneal stroma and whether it differs from the options of adjuvant treatment for the sclera. As seen in case 2, appearances can be deceiving. What appeared to be an aggressive large tumor turned out to be quite a superficial one. Lastly, simultaneous intraocular surgery like cataract is best deferred in cases of OSSM. And a close follow-up is mandatory to look for any signs of intraocular seeding and extension. We did not observe any in our case over a period of 5 years. Thank you very much.
Thanks, Hiren. Basically, we wanted to present this to highlight the fact that you can have OSS involving different depths of cornea, especially in xeroderma patients. So you must be ready for from lamellar keratoplasty. Sometimes it can become penetrating keratoplasty. Although you're definitely worried because of the intraoperative seeding that is possible when you're doing a penetrating keratoplasty. But the other question that comes to your mind is, if you're doing a lamellar keratoplasty, how much deeper should you get? You know, you have excised the lesion. How much deeper should you get to make sure that you have done a reasonably good clearance? And also, we should keep in mind the fact that there are some reports of decreased endothelial cell density in xeroderma patients. So, will these patients eventually require a penetrating keratoplasty in the future? The last case where we had to do a penetrating keratoplasty was because intraoperatively we saw that mass was involving the desmus membrane, and although we saw the cataract like we discussed last time, we decided not to address the cataract at that point of time. We waited for about 6 to 9 months and thereafter addressed the cataract. If there are any suggestions or opinions about any other points.
One comment here could be, one of the options in such cases would be maybe a lamellar excision followed by plaque brachytherapy to treat the residual lesion. We've had a couple of cases, Dr. Santosh has had many, where we've treated similar situations with lamellar excision and plaque brachytherapy. And some of these patients have been following up for many, many years now. The other thing is that one thing which I wanted to know more about is that what percentage of depth would you prefer to do a lamellar keratoplasty in the same sitting? because as far as my mind works in these cases, I would prefer to, maybe if it's a 40% depth involving tumor, probably I would suggest that you do a lamellar excision, do a multiple layered amniotic membrane grafts, and wait for the histopathology report to check for base involvement. If the base is involved, probably a plaque brachytherapy, and if the base is negative, then maybe you just follow them up to look for recurrences.
What
So when
about
do you actually decide that lamellar keratoplasty is a must in these cases?
I
Dr. Ram?
agree with Vikas. In patients who have corneal stromal invasion, we have learned that plaque brachytherapy works very well. There is no corneal melt. And it is said that in xeroderma pigmentosum, radiation is relatively contraindicated because it worsens their DNA repair mechanism, which is already faulty. But plaque brachytherapy somehow does not work against them. In fact, it works in favor of them. We have patients where in the area where plaque has been done, there has been no recurrence at all, but the patient would have recurred on the nasal limbus, for example, if a plaque has been done temporarily. So doing plaque brachytherapy is not going to worsen the patient. It's actually beneficial in conserving the eye and not having to do a penetrating keratoplasty or a lamellar keratoplasty, especially in xeroderma pigmentosa.
I just wanted to ask one thing. I mean, I'm sure it must have been discussed last time I was not there. But what about frozen section guided excision in such cases? I mean, this is xeroderma pigmentosa, but otherwise, all the cases where you have to do a lamellar graft, you can always send it for frozen section guided excision.
Pathologists are here, maybe they can comment. Kaustubh has a lot of experience with frozen section, and Dr. Biswas is also here. Kaustubh?
Also,
So the
lost
depth.
connection.
Frozen section can show the depth of the lesion quite easily, and we can
How
tell that.
comfortable you are with,
So
sir?
that is what we do at our, I mean, that is how we would, do every time we send a layer of the tissue, send it for frozen section. And when the edges as well as as for the depth, the pathologist says, and we wait. I mean, I know in the OR, you have to sit and wait for the report to come. That is the thing. So we wait. And if they say there are still cells there, then we go still more deeper. And then again, we wait. I know it's a long surgery, but that is what we do. But I think Dr. Bishwas sir will be able to tell more about
No,
this.
I don't think there is any problem for looking at the depth of the lesion, and the stroma is. So we can see that there is a good bit of stroma is there. Then we can tell that it has gone half of the stroma, or the significant amount of the stroma if it is involved.
Yes, sir. There is no problem in looking at the depth as such, but the tumor is large. So if the pathologist takes just one section randomly through one part of the stroma that you have sent, there is possibility of multifocality of full thickness invasion, or in the area where he has taken section from, there may not be any stromal invasion at all. But in the other area, there may be. So they have to bread loaf it and take multiple sections
Yes,
and report on
Yeah,
all
I
of them.
agree with.
Otherwise, we are going to miss it.
yeah,
That
yeah.
is
No,
the
no,
limit.
we'll take a different level, different
Right.
2, 3, 4 sections we'll take,
Right.
and this is all usually done.
Yeah, so we give multiple sections only. And another thing is, like in xeroderma pigmentosa, the series that we have from our center, they tend to be younger. The patients tend to be
Yeah.
younger. All the patients who are
Bilateral multifocal.
less than 25 years in our series, and the recurrence rate is higher. It's more
Correct.
than 60% again in our series. So I think that is something which also needs to be kept in mind. So that is why I'm saying frozen section guided excision. And I know we do it under general anesthesia because it takes a lot of time. So those cases, whenever we do a frozen section guided excision, it is under GA.
I think with
My
the
question.
advent of plaque brachytherapy, the management has probably changed with respect to these lesions. And these, I think, which were shown were from the earlier years when either plaque therapy was not there or was just about coming through. The one take home would be that in these lesions, yes, plaque therapy is something that we should uh, actively consider instead of, a simultaneous keratoplasty.
The other disadvantage of going deeper is that then you have to maintain the tectonic support, you have to put in a tissue. And if you put tissue and there is a recurrence below the tissue, you can miss it.
Exactly.
Yeah, I think I
won't be able to
completely
see.
agree.
That's where I think the brachytherapy is that you debulk it and whatever is remaining, the brachytherapy can, so tectonically the globe still remains strong and you can always come back and do a visual restorative procedure.
Like this was done a few years ago. The concepts have changed now.
Absolutely,
Maybe
yeah.
we should look at plaque therapy now if we have these cases.
Correct.
So we go to the next case, which also deals with xeroderma pigmentosa, and Dr. Sunita Chaurasia will present her case on plaque therapy.
Thank you, Dr. Geeta and organizers for including this case. So I don't manage the oncology part, but yes, because we manage cases of xeroderma pigmentosa, and when we do a transplant in these eyes, many of these cases can have a recurrence of OSS, and so I think it is important for the corneal surgeons to know what is what is a suspicious lesion. So I think my case deals with that aspect of xeroderma pigmentosa and the important clinical signs which can give clues towards referring the patient to the oncology services. So this was a girl who was a 14-year-old female with xeroderma pigmentosa, and her vision at the time of presentation was 2200, and the other eye had a poorer vision. So this eye was taken up for surgery because she had a central scarring. And so after penetrating keratoplasty, I prefer to do penetrating keratoplasty in these patients because we have seen that many of these patients after DALP do not have a very predictable outcome because the endothelium tends to be compromised in these patients. There are patients who present with corneal edema relative to the anterior stromal sky. In those cases, I prefer to do DSEC, but the patients who have predominantly anterior stromal scarring, I prefer to do a PK in these eyes. And this patient, after penetrating keratoplasty, had a visual acuity of 20/40, which was maintained till 6 months, following which we started removing her sutures. And thereafter, when at 6 months of follow-up, she started complaining of increased redness and photophobia in the operated eye. And what examination revealed was a dry ocular surface and increasing congestion, which kept happening at subsequent visits. Now, at this point of time, like there was, she was doing quite well after penetrating keratoplasty, but then her symptoms were increasing. And that's when we referred her to oncology services because there was something unusual about her eye, because initially doing well and subsequently having complaints was something unusual in this course. So 1 to 2 weeks later, she got an appointment with the oncology services. And when she was evaluated there was a suspicion like she could be having OSSN and her lesions had increased. So at that time, the picture on the right side shows that there are increasing lesions at the site where suture removal was done, and there was increasing congestion. So the patient was planned for alcohol keratoepitheliectomy to rule out OSSN. These pictures have been taken under low illumination because she was extremely photophobic. The histology of the alcohol keratoepitheliectomy revealed that the patient's specimen showed severe dysplasia, and subsequently post AKE she developed a sterile keratitis. And this was managed with prophylactic antibiotics and lubricants, and following resolution of which the plan was that she will be taken up for surface plaque brachytherapy by the oncology services. So this is at the last visit when she was seen. So her lesion has resolved, the sterile keratitis resolved, and she was given brachytherapy. And following resolution, she had a visual acuity restored to 20/60. There was a faint scarring in the graph in the central area where she had developed keratitis, and she had recurrence. She was recurrence-free after this. Now, the key messages I would say for corneal surgeons is that to remember that XP patients can have OSSN after keratoplasty, and it's important to recognize it early. Clinical features may sometimes be very difficult to elicit because many of these patients already are scarred, they have pigmentation, the surface is vascularized. It's really hard to know like what is unusual in these eyes. Some of the early clinical cues, what I feel could be that there's any unusual discomfort in the eye which was absent earlier, increasing congestion, vascularization in the suture sites, and infiltration in suture sites. These are the early clinical signs of suspicion. The lesion can rapidly worsen, as was seen in this particular case. In 1 to 2 weeks, she had a rapid worsening of the lesions. Timely diagnosis can help in the management and recovery of the visual acuity. And diagnostic biopsies such as AT can lead to sterile lesions, which should be managed first before definitive therapy. I acknowledge our team, Dilip Kumar Mishra from Oncology Ocular Pathology Services, and Swati Kalki and Vijita for helping in managing this case. Thank you. So I would have a question for Dr. Santosh and others to, like, in your clinical experience, what kind of early clinical signs have you seen following keratoplasty in these eyes? Many of these patients present later, but what are the early clinical signs which we should remember when seeing these cases in the follow-up period?
In especially OS, development of OSSN, right?
Yes, yes.
Yeah, in whatever I have seen, I have never seen it in the graft. I have seen it at the graft host junction and I have seen it in the host. And this possibly was in the graft. That makes it very unusual.
But in the graft, isn't it unusual because the grafted cornea was a PK button? So unlike, is it commonly seen, or is
That
it
is
just
very
that?
unusual. I have not seen, in fact, I was collecting our xeroderma pigmentosum in LVP earlier, and then you, I think, continued the process. I think it's under publication right now. So I had never seen a patient, grafted patient of XP who has developed a OSSN in the graft. I've always seen it at the graft host junction or in the host, but this is very unusual.
Thank you, sir.
I do think there are reports of transmission of, or whatever. I mean, even I have not seen anything in a graft like this. It just stop short at the graft host junction.
Right.
At all.
The case that was presented earlier post PK, the recurrence on either sides was in the graft, in the host, stopping short of the graft.
Right. So whenever there is a graft host junction OSSN or in the host OSSN, I would prefer topical interferon because that's very gentle on the ocular surface and doesn't tip the balance of the graft. But yeah, plaque is something that you can consider, and I have done only one plaque in such a situation where there is a post-graft OSSN. But this worked beautifully well. In fact, there is a very minimal corneal scarring at the end of the entire treatment. So that works in favor of the patient.
If I've understood correctly, Geeta, 1 minute. So plaque therapy in a corneal OSSN is usually for anything that involves a stroma. Is that right? Is that what?
Yes.
Is that when it is done?
Yes, it involves full thickness of the stroma. Still, you can do plaque. Even if there is ciliary body invasion, segmental, you can still do plaque. If there is angle invasion, you can still do plaque. Earlier, we were enucleating them. Because ciliary body melanoma, we do plaque with excellent success. And the dose there is 10,000 centigrade. Here, we are talking about 5,000, 6,000 centigrade. So plaque is very useful for limited intraocular extension as well.
Thank you.
In fact, what was impressive in this case, Sunita, was the eye looked so absolutely quiet after the brachytherapy was done. Unlike what you see in XP patients.
Yeah.
I don't know if there was any other effect of the brachytherapy apart from its effect on the OSSN.
Oh, yeah, so it was very surprising also because the thing is she had developed a sterile keratitis after AKE, and subsequently after resolution it was like a completely dramatic picture after surface plaque with brachytherapy. And she's been maintaining a really good vision after that.
Right. Maybe low dose radiation helps in preserving graft and, minimizing the risk of graft rejection and failure. Who knows?
Don't give us ideas, Dr. Honavar.
Come again, Santosh. Come again. You said something.
Become the norm for high risk grafts.
Yeah, you come again. What did you say?
Low dose radiation may reduce the risk of graft failure or graft rejection. Who knows? I said.
It may reduce the antigen presence.
Amrita will do that study next.
Yeah,
It may reduce the number of antigen
the point.
But give me an idea now.
and improve the graft survival. Yeah, it's possible, yeah.
So we'll move on to the next case by Dr. Manokamna. She will be presenting on diffuse pigmented lesions. This is the melanoma.
Thank you, CSI, for this opportunity. Next slide, please. I'm presenting a case of a 54-year-old male with complaints of black pigmentation in the white part of the right eye since 20 years, and which was increasing in size for last 5 years. On slit lamp examination of right eye, there was diffuse pigmentation involving whole of the temporal and inferior bulbar conjunctiva and extending up to the medial bulbar surface. Corneal involvement was also noted, and only 12 o'clock to 3 o'clock area was spared. A raised nodular lesion of approximately 5 into 3 millimeter in size was noted temporally near the limbus. There was no involvement of the tarsal conjunctiva, and the other eye had no similar lesion. On ASOCT at the involved area, the conjunctiva had subepithelial hyperreflectivity and the cornea showed epithelial hyperreflectivity. In view of change in size of the lesion, we decided to go ahead with the excision biopsy along with cryo to the margins and alcohol epithelectomy with or without alloslit. Next slide, please. So first, complete excision of the conjunctival pigmented lesion was done by blunt dissection, leaving a surrounding of 4 millimeters of healthy conjunctiva. Alcohol epithelectomy was done to remove the epithelium. Then double freeze-thaw cryo was done to excised edges. The gap was sutured using a tenovitral suture. Amniotic membrane was applied to the bare area and stuck with fibrin glue. Alloslit bits were then placed over the amniotic membrane and a bandage contact lens was applied. Next slide, please. On histopathology, the pigmented lesion turned out to be PAM with severe atypia with a Siemens score of 5, and the nodular lesion turned out to be a compound cystic nevus. Next slide, please. So we have followed up the patient for now 15 months and there is no evidence of recurrence. Next. So the key points to highlight in this case are that it was a large pigmented lesion, there was nodularity, there was corneal involvement, and there was recent change in size. There was no tarsal pigmentation noted, and histopathology was suggestive of combination of PAM with atypia along with a compound cystic nevus, which I feel is a rare combination. And we have observed the patient for any recurrence. And the large bare area can have issues with reconstruction and the role of alloslit in such cases. Thank you.
Comments from the panel?
Very well managed case, but the coexistence of PAM with nevus is very unusual. I don't know whether it's reported or not. It's extremely, I mean, why should it? There is no even pathological basis for a PAM to have a coexisting nevus.
I don't think the nevus can lead to PAM.
Absolutely.
At this. I think it's only PAM probably.
So actually, we had the histopathology slide. I mean, Dr. K reported on the slide. Diagnosis was basically this, the combined thing. We actually got Dr. Stephen Dubovy. I think there's someone
to speak louder.
So what is reported by Dr. Stephen Dubovy also, he was also of the opinion that it is a coexistent lesion, which what was very rare. In fact, the nodularity in the lesion was basically what made us feel that there was probably a change towards melanoma, which is the reason why we decided to go ahead and excise the lesion.
Right.
And the question that I had was, in this case, the nodularity and the flat pigmentation was conjoined. But if you have a patchy PAM involving your entire bulbar surface, and in one particular area you have a nodularity, then would you just go and excise only that area which is nodular with a 4 millimeter region margin and a map biopsy for the rest of the bulbar surface? Would that be the approach in a localized nodularity?
PAM can be multifocal and diffuse, and PAM need not be contiguous also. So if there is bulbar PAM, then there could be a PAM in the palpebral conjunctiva or in the phonacial conjunctiva. It need not be contiguous at all. So in the situation that you described, what is reasonable to do is excise the nodular component with all 4 millimeter clinically clear margins, cryotherapy, etc. And rest of the pigmented area, we can do a map biopsy. And if on map biopsy it turns out to be PAM with atypia, then you have medical management to back up. If reasonable cycles of mitomycin C does not work because it works in only half the patients, then you can go back and cryo those areas of residual PAM. You can excise them. There are a lot of other options that will come up.
Right.
But if a patient has developed melanoma from one aspect of PAM, it is likely that the other areas will also crop up melanoma over a period of time. So you have to be very careful with those patients.
So, how good is the response to mitomycin in these eyes?
About
If you have
50%.
does it
50%.
50%?
In fact, another point we wanted to highlight was that we felt that the extent of symblepharon in this eye, which would have been quite large, was probably reduced by the use of alloslet and the rapid corneal epithelialization that we achieved in the postoperative period. We have a 15-month follow-up now, and the patient does not really exhibit any significant symblepharon or limbal stem cell
Right. It
deficiency.
may
And
be good
not
to
on.
mention the risk factors. People see PAM very commonly. PAM is something that you should consider when you see unilateral or asymmetrical pigmentation. Asian Indians definitely will have racial melanosis. All of us will have some amount of melanosis that will be perilimbal bulbar. But if there is pigmentation in the pharyngeal conjunctiva, in the palpebral conjunctiva, or if there is asymmetrical pigmentation more intense in one eye and extending for more than 2 clock hours, you should consider PAM as a differential diagnosis. And every clock hour increase in the size of PAM increases the risk of melanoma by a factor of 1.7. That is by the SHIELD study. But generally, the larger the PAM, more is the chance of it turning into melanoma. Thicker the PAM, more is the chance. So OCT can definitely help us judge the depth of the lesion. And if it is a thicker PAM, then more is the chance of it being atypical, vascularization, non-bulbar location, and feeder vessels.
Um,
How do
I
you
think
choose your alloslet donor? Where do you choose your graft from?
so. We harvest the limbal tissue from the donor eye. If there's a keratoplasty that's planned for the same day, then you could use the same tissue for two different cases, harvested in a sterile fashion. And usually, we prefer that the donor is less than 70 years of age and the tissue is relatively fresh within 48 hours of harvesting.
Nice, work very well.
There is a question by one of the attendees asking what are the list of centers offering plaque brachytherapy? Maybe Santosh can.
Yeah, in Hyderabad, there are 2 centers. We do it and LVP does it. And in Shankanetrale, I think they use iodine. RP Center now has. And Delhi Shroff Charitable Eye Hospital has. And I think Medanta also has now. Swati Bansal was trying to get one and she probably has it already. Now it's very easy to get plaque because now the cost is less than 5% of the imported plaque. So every center which can have a radiation oncologist and a radiation physicist and the safety guidelines that AERB has prescribed can have plaque brachytherapy facility easily. And the safety guidelines are very easy to follow. It's not that it is difficult. It's protocol. It's a protocol that we have to establish. You have to have a separate OT and stuff like that, and waiting area for the patient, admission area, all that can be easily followed.
Need some space post recovery also. The patient is there. I mean, you need a different setup. Can you do something else in that after you've done your plaque therapy?
No, we cannot because these are government guidelines and government guidelines are same for ant to
So
elephant.
I think
Uniform
that is the most important thing. You need a dedicated space to do it,
Absolutely.
which cannot be used for anything else.
Right. And if you lose it, it is a criminal offense, non-bailable. So you can't
My
even
God.
lose your plaque ever.
So we'll move to the last case for the day, that is by Dr. Devyani on bilateral fleshy pink conjunctival lesions.
Is my screen visible? Is my screen visible now?
Yes, yes.
Yeah, okay. Thank you, CSI, for this opportunity. We're talking about a patient who had a bilateral flat pink-looking conjunctival lesion. This was the patient was 20 years old, male patient, who presented with this redness in both his superior fornices since 2 months. He had been treated elsewhere with topical and oral steroids, and there was no improvement. Uh, on examination, this was the extent of the lesion in the right eye, and this was the lesion in the left eye. The right eye was a larger lesion, 3 to 4 clock hours, and abutting the nimbus. The left eye was a relatively smaller one. ASOCT showed this flat subconjunctival lesion with a normal epithelium seen, and this was the extent of the lesion on the cross section. These are other slices. The left eye SOCT showed another similar looking lesion. The differential diagnosis we had in mind was obviously a lymphoproliferative lesion, conjunctival lymphoma being the most dangerous. Its benign cousin, the lymphoid hyperplasia, reactive or atypical, and probability of a conjunctival myxoma was also considered. In order to differentiate and in order to understand what was happening, we needed a tissue diagnosis for which a right-sided excision biopsy with histopathology was planned. This is the pre-op and the post-op picture of the same patient in the right eye. On histopathology, we found the pathologist saying that this was a lymphoid hyperplasia, and there was no evidence of any lymphoma. My questions actually with this case, which was relatively straightforward but raised a lot of questions, was that do these lymphoproliferative lesions need us to get a hematologist involved in the whole process? How accessible is immunohistochemistry to these cases, and how important are these? Is this for prognosticating these lesions, especially considering that the left eye also has a similar lesion? And would you prefer an incisional biopsy or an excisional one? The last question being, is the excision biopsy warranted for the other eye? And or can we relatively be sure that this was the same thing that happened for the other eye as well, and label it as lymphoid hyperplasia? And how often do we monitor these patients? I leave the questions to the panelists.
I think immunohistochemistry is a must in such situations to differentiate from benign reactive lymphoid hyperplasia to lymphoma. So even if it looks clinically, histopathologically looks like benign reactive lymphoid hyperplasia, it can be deceptive. So CD3 and CD20, particularly CD20, will be positive in such situations.
Right.
Benign reactive lymphoid hyperplasia is polyclonal, whereas lymphoma is
monoclonal.
Monoclonal. So that differentiation has to occur. And you're right in excising it, because one part of a lymphoproliferative lesion can be benign reactive lymphoid hyperplasia, another part can be atypical lymphoid hyperplasia, and a third part can have lymphoma. So it is a kind of evolving disorder. Benign reactive lymphoid hyperplasia can evolve into lymphoma, that is known. And also, if it is bilateral, one eye can have benign reactive lymphoid hyperplasia and the other eye can have lymphoma. So whenever there is a lacrimal gland lesion which is lymphoproliferative, we are supposed to biopsy both eyes on protocol, not just one eye, and label the patient based on one eye diagnosis. And if it is confirmed that it is benign reactive lymphoid hyperplasia, your treatment is over. You know, there are other forms of treatment such as topical steroids, intralesional steroids, subconjunctival steroids, systemic steroids, cyclosporin has been used, and even doxycycline has been used. Systemic doxycycline has been used for benign reactive lymphoid hyperplasia. So treatment is easy for that, but patient has to be under follow-up because, well, it is not so common conjunctival. In fact, if I remember right, only 1% of conjunctival benign reactive lymphoid hyperplasias develop into lymphomas over a period of time. But for orbital BRLH, it is 20 to 30%. That's a very high conversion rate. For conjunctiva, I think we're quite safe.
Thank you, sir.
Would you suggest that she does an excision for the other eye also?
Or try steroids, topical steroids, if it works, or subconjunctival steroids, if it works, that's fine. Otherwise, ideally, you should excise it. And since excision is simple anyway, it's well defined, she could get the entire lesion out in one eye, so probably she can do the same in the other eye.
Also, role of hematologist involvement, sir?
Not really.
Not required.
Pathologist.
Not required.
If the pathologist says that there is monoclonality, then comes the role of course, they have to
oncologist.
do oncologist. Yes.
I think related to this particular case, I just thought that I will share a few similar such cases that we have seen, which basically looks like I mean, lymphoproliferative lesions, that they can all look very similar, but they can be very different on your histopathology. So this was a 25-year-old female who presented with these bilateral pinkish subconjunctival lesions, which clinically we thought could be grouped under lymphoproliferative lesions. But after doing the biopsy, this patient turned out to be a benign reactive lymphoid hyperplasia. In this particular case, Dr. KK felt that there was more of eosinophils, and that's why he labeled it as very allergic, and we didn't really go in. Yes, we didn't go in for immunohistochemistry. But this was another patient, young again, 25-year-old male, who presented with a diffuse lesion very similar to the one that Devyani was showing, probably much more wider, where we initially did an incisional biopsy, which turned out to be an atypical lymphoid hyperplasia. And the immunohistochemistry showed a predominant small B cell lymphoid hyperplasia. And in fact, this patient also had a further gene rearrangement study which showed monoclonality. And this was the time when patient had a hemato-oncologist opinion, and a bone marrow biopsy and aspirate was done, as well as a PET scan was done, all of which was normal. And then this patient was kept only on. We went back to remove the lesion to the maximum extent that we could, and then the patient was kept on systemic steroid therapy by the hemato-oncologist for a period of 6 months. This is again another similar looking lesion, which we thought was lymphoma on clinical examination, but then your histopathology showed histiocytosis, and this was and the immunohistochemistry was also suggestive of a Rosai-Dorfman disease.
Yes.
So all these lesions look very similar when you see them, but it's only the histopathology which can tell you what you're dealing with. And this was another, so the previous patient, we were able to excise most of the lesions, didn't have any other systemic involvement, and is on a regular follow-up. But this was another patient who came with bilateral large lesions in both the eyes. In fact, in the initial starting phase, I guess this patient got wrongly misdiagnosed as a scleritis and was started on immunosuppressive therapy elsewhere. And then he came with these kind of large lesions in both the eyes. And I did an incisional biopsy, which again showed that this was a Dorfman disease. But because it was so extensive and bilateral, the hemato-oncologist decided to give him chemotherapy. And the lesions did start resolving after that. And a similar variant of this was a young patient who presented with this kind of a large lesion. Again, incisional biopsy showed that this was sinus histiocytosis, but because of the coexisting features of short stature and sensory neural deafness, this patient was categorized as Faisalabad histiocytosis. And I was told that by the hemato-oncologist that they've started the patient on chemotherapy, and I was waiting, assuming that I would have to go ahead with a surgical excision after chemo reduction, but the lesion just disappeared completely on chemo, so it became a chemotherapy, and the lesion just disappeared completely, and I didn't have to do anything for this patient. But again, goes to show how much important histopathology is in these eyes. This is again another similar lesion, but this turned out to be again monoclonal, but monoclonal for plasma cells, and this was a plasmacytoma. And the hemato-oncologist again asked for a bone marrow aspirate and PET scan, both of which were normal, and the patient is under a regular follow-up. And this is another similar looking patient. She presented in both the eyes with this kind of a flat subconjunctival lesion, which again, 60-year-old female, we thought was probably a lymphoproliferative lesion. It's a subconjunctival lesion, and the histopathology, actually the immunohistochemistry again showed a polyclonality, and they wanted us to rule out IgG4, which was also normal. So ultimately, the final diagnosis that this patient had was that it's probably a primary Sjogren's syndrome, because the histopathology was very similar to what they see in the lip biopsies in these patients. And she was started on systemic steroids, and subsequently you can see this is the IV operated, this is the IV didn't operate, but then everything kind of just settled down over a 3-year follow-up. She's absolutely fine. This is again another similar lesion, but then on histopathology this turned out to be a conjunctival stromal tumor, and which is one of the variants of conjunctival myxoma. So
Yeah,
this was a reason where we couldn't actually excise it completely, and there is no case in literature where it has been partly excised and you have left behind a part of it. So we weren't really sure of what to do. So we actually wrote to Dr. Gross-Nicholas to get his opinion. And fortunately, since the patient was going back to the US, we asked her to follow up with Professor Gross-Nicholas himself. But the opinion that was given to us was nothing is required, just observe to look for any evidence of recurrence in this situation. And this is the variant of, POST is a variant of myxoma. So this was a patient of myxoma who underwent a surgical excision because he couldn't wear his contact lenses. And in this situation, you have to do an echocardiography to rule out any associated atrial myxomas. This man didn't have one. You want to basically rule out a Carney's complex. So I just kind of put together a few cases which look very similar on clinical presentation, but it's only histopathology which tells you as to what is the exact clonality or the maturity of the cells or the type of disease that you're basically dealing with in these situations.
So salmon pink is, not specific for lymphoma. Every patient that you showed had the same color. That's a very important point, actually. We should never be under false sense of security looking at our lesions, thinking that it is a lymphoproliferative lesion. We have to biopsy. Biopsy is the key.
So that nodular lesions with the congestions, we should take the history of pain. If the pain is associated with, we should rule out the nodular
scleritis. But that's
nodular sclerosis. It can, particularly those congested one, it looks that a differential diagnosis of scleritis to be ruled out.
With myxomas, we do read about Carney complex and association with the cardiac myxomas. But how often have we seen cardiac myxomas occurring with conjunctival myxomas? I've never seen an occurrence.
So rare. It is described in the literature, but it is so rare. I don't think we will see one in our lifetime, but maybe if you put together all the cases, you might, yeah, 10% is supposed to be the association.
And
but
then
I haven't seen 10% so far.
And maybe at the time when we are seeing the patient, there's nothing, but then there's no clarity as to, how long do you have to follow up these patients and keep getting their echoes done. We don't know that.
It could be metachronous. Now, at the time that you investigate, the patient may have nothing.
And then patient is all right. Patient also forgets and stops following up after a while. Then we don't know.
I think any other points? Dr. Rama, you have anything else to say? Any other points? Any comments by the panelists? I think if not, we really enjoyed both the sessions, and thanks to Dr. Unawar, Dr. Vikas, Dr. Kaustubh. I think his line, he got disconnected from the webinar because of some power issues. Dr. KK for the last time, Dr. JB. We really had a very interesting session on ocular surface tumors, cleared a lot of our concepts, doubts, and preferred practice patterns. I would like to thank all of you for all the inputs that you gave. Today we had a very interesting lineup of cases, and I would like to thank everybody who submitted cases. We couldn't select all of them due to want of time, and thanks for all your presentations, the audience who's been very interactive both the times with multiple questions. A summary will be prepared for both the sessions and will be mailed across to the members of the society. Thank the office, the team, who basically take care of the entire program and make sure that it runs very smoothly, both Shabina and Vinay. And of course, our sponsors for today, Allergan, for making this webinar a very successful one. So with that, we come to the end of this session on ocular surface tumors for Kerakonnect. Thank you so much.
Thank you so much.
Thank you,
Thank
Dr.
you, Geeta, for organizing both of them so well.
Thank you.
All those things can be done. That is not a problem. Just remain calm.
Thanks everyone for joining us, making it very interactive. Special thanks, Dr. Bhaskar. Always a very good learning moment.